Welcome back to the deep dive. If you're currently swimming in a sea of note cards trying to distinguish between stridor and wheezing, or just remembering if epiglottitis is viral or bacterial, well, this deep dive is absolutely for you.
That's right. Today, our mission is pure efficiency. We're going to turn those textbook lectures on pediatric respiratory health into the kind of crisp, actionable, clinical reasoning that you need to conquer the NCLEX.
So we're going beyond just memorization.
Way beyond it. We're focusing on the pathophysiology, because, if you understand the mechanism, the intervention just becomes logical. It clicks.
And we have a pretty tight agenda today. We're starting with the foundational vulnerability of a child's airway because, pediatrics is not just little adult medicine.
None at all.
Then we'll hit the acute emergencies, the triage, the red flags, and the critical differential diagnoses like the croup syndromes.
And after that, we'll pivot into the chronic masterclass. We're going to set up the high-yield management pillars for asthma and for cystic fibrosis.
We've consolidated all your sources, your notes, your flashcards. So let's make this information stick, really focusing on clinical application and, of course, high-stakes safety.
Let's do it. Let's unpack this crucial material.
Okay, so let's start with the basics. Section 1. When you look at an infant or a young child, the differences in their respiratory system, they're not trivial. They are pretty profound, and they increase their risk of deteriorating, and fast.
Very fast.
Mm-hmm.
And if we're going to start with the most critical anatomical difference, the one thing you have to remember, it's simply the size.
The airway diameter.
The airway diameter. It's just so small. And this sounds obvious, right? But the geometric impact is huge. If you think about, physics for a second, Poiseuille's law says that resistance is inversely proportional to the radius to the fourth power.
Okay, so you're saying a tiny change in the radius has a massive effect on resistance.
A massive effect. Let's make it concrete.
Yeah.
The sources always use this 1 millimeter example, and for good reason. Imagine just 1 millimeter of swelling from inflammation or thick mucus.
Yep.
In an adult's trachea that's wide, that 1 millimeter might just, cause a mild cough. No big deal.
Right.
But in an infant's trachea, which is only about 4 millimeters wide to start with, that same 1 millimeter of swelling reduces the airway cross-section by up to 75%.
75% from 1 millimeter.
75%. That
Yeah.
tiny bit of swelling leads immediately to massive resistance, a high work of breathing, and very often pretty severe respiratory distress.
So when we see a child with even mild respiratory symptoms, a little bit of swelling, a little bit of mucus, we have to triage them so much faster. Their ability to compensate is it's so brief compared to an adult.
That's the high-risk implication right there. And then you have to recognize that the distance between structures is shorter.
So everything is closer together.
Everything's closer together. And that anatomical proximity means that an organism that gets into the nasopharynx has a much, much shorter journey down to the lungs.
So a simple cold can become pneumonia much more easily.
With alarming speed. A simple URI in a toddler can turn into a serious lower respiratory infection like pneumonia or bronchiolitis very, very quickly.
And what about the ears? That seems to be a chronic battle for parents, linking the upper respiratory tract to ear infections.
Absolutely. The third critical difference is the eustachian tubes. In kids, they are shorter, they're wider, and they're more horizontal compared to in adults, which are longer and more vertical.
So it's basically a straight shot for bacteria.
It's a near straight, easy pathway for infectious material to travel up from the nasopharynx. Especially, during bottle feeding or when they're lying flat, it just flows right into the middle ear space.
Which is why we see so much otitis media.
So much OM. And as the child grows, the skull structure elongates and the tube starts to angle downward. That's why ear infections usually become way less frequent after about age 7.
Okay, that makes perfect sense from a structural standpoint. Now let's talk about that key nursing assessment point you hear all the time. Obligatory nose breathing in infants.
This is a must-remember fact. It applies to infants generally under, say, 4 to 6 months old. They are naturally obligate nose breathers. So if their nasal passages get occluded, like with the thick, copious secretions you see in bronchiolitis or RSV, they physically struggle to compensate by breathing through their mouth.
They just don't have that reflex yet.
They don't have it mastered. So if you walk into a room and a 6-week-old is actively struggling to breathe but has thick nasal secretions, what do? The immediate low-tech intervention is clearing those passages.
You suction. You don't wait for the chest x-ray.
Precisely. You suction those nares, often using saline drops first. It's a critical, life-saving initial nursing intervention because you're recognizing that their fundamental compensatory mechanism, mouth breathing, It just hasn't developed yet.
Okay, so let's shift from the structure to defense system. Knowing the developmental timeline of immunity, that seems really crucial. The child's age gives us a powerful clue about what's probably causing their
A
illness.
huge clue. And we can track that timeline right from birth.
So let's start there. The newborn.
For infants under 3 months, there's a protective period. They are shielded by maternal antibodies, the IgG, that's transferred across the placenta. So their infection rate is relatively low.
But if they do get sick,
If they do get sick, we treat it with extreme caution because we know they lack their own robust, active defense mechanisms.
but that shield, it doesn't last forever.
No, it fades quickly. Between 3 and 6 months, those maternal antibodies disappear, and the infant's own immune system is still very immature.
Yeah,
This is the window.
the danger zones.
It's the danger zone where the infection rate sharply increases, making them extremely vulnerable to conditions like RSV. I mean, it's the leading cause of hospitalization in this age group for a reason.
And then they start moving, they start interacting, and the infection volume just explodes.
It explodes. Toddlers and preschoolers, the daycare years, they are constantly battling viral infections.
Yeah.
They're the primary spreaders. They put everything in their mouths, and their adaptive immunity is still just cataloging all these new threats.
But then something changes around age 5.
It does. Around age 5, the frequency of infections starts to decrease. And here's the key NCLEX differentiator. The common mistake is assuming the child is suddenly encountering fewer viruses.
Right.
But that's not it. That's the trap. Viruses are just as prevalent in elementary schools as they are in daycares. The key reason the illness frequency drops is because of increased immunity due to repeated exposure.
So their immune system has built up a library of defenses.
Exactly. Their adaptive immune system now recognizes these threats, so they're either asymptomatic or just mildly symptomatic, instead of getting acutely ill every single time.
That reframes things from like environmental avoidance to internal development. So how do we use this timing knowledge to answer preventative care questions, especially about otitis media?
Prevention is multifaceted. It's often counseling parents on environmental and feeding techniques. We link that high-yield fact about the short, horizontal eustachian tubes directly to prevention.
So propping the bottle is a major no-no?
A major no-no. We teach parents that child should be upright during feedings, and bottles should never be propped. Propping lets milk pool in the pharynx, and then it just easily flows up that vulnerable tube.
And what about environmental factors?
Absolutely crucial. Avoiding tobacco smoke exposure is a big one. It's a known risk factor for respiratory inflammation and OM. And the source material explicitly links exclusive breastfeeding until at least 6 months and maintaining the immunization schedule as primary preventative strategies.
The pneumococcal vaccine, for instance.
Right, it targets common OM pathogens, so all these things work together.
Okay, before we jump into acute illness, we have to pause and look at the psychosocial component. The emotional distress a child feels during hospitalization is just as clinically relevant as their O2 sat, and NCLEX loves testing therapeutic communication.
It's the difference between treating the disease and, treating the patient. And the primary stressors, they change entirely based on the child's cognitive and emotional development.
So let's start at the beginning. The infant, from birth to 1 year. What are their core needs that get so disrupted?
Infants, they're not cognitively aware of the illness itself, but they are highly, highly tuned in to their parents' emotional state and their own physical comfort. So the key stressors are separation anxiety, especially after 6 months, stranger anxiety, and the profound disruption of their routines.
Sleep and feeding.
Sleep and feeding, exactly. So the nursing action has to focus on preserving that sense of security.
So it's all about continuity.
It's all about continuity and presence. We aggressively encourage parental presence at the bedside, and we make every effort to adhere to the infant's home routine. Feeding times, comfort items, sleep rituals. We're trying to minimize that sense of abandonment.
Okay, next up. The toddler and preschooler, 1 to 5 years. This is a tough group because their imagination and, their magical thinking really kicks in.
It's a very challenging stage. The major stressor is still separation, but now we add in these cognitive distortions. They don't have a mature understanding of anatomy. They fear their body integrity, that fluids might leak out. And critically, they often interpret pain or procedures as punishment.
Punishment for being bad.
Punishment for some real or perceived transgression. And that idea that illness is a punishment is a profound barrier to care.
So how do we, as nurses, combat that misconception?
We have to be so meticulous with our language and in giving them some control. Nursing actions include allowing small, simple choices. Do you want the red cup or the blue cup for your medicine? explaining procedures very simply, providing a nightlight.
And you definitely avoid phrases like, be a brave boy and you'll get better.
Absolutely. That just reinforces the idea that their behavior is somehow controlling the illness.
Okay, moving to the school-age child, 6 to 12. They have a better grasp of cause and effect, but they bring in new social pressures.
Yeah, they understand body functions, they understand the reasons for their illness, but the stress now shifts to loss of control, loss of privacy, especially around bodily exposure, and really importantly, separation from their peer group and school.
And the nursing intervention here, which I know is highly testable, is fostering their sense of what?
Industry,
Yeah.
their need to feel competent and productive.
So we let them participate.
We actively let them participate in their own care, charting their vitals, helping with dressing changes, doing their schoolwork, arts and crafts. They need to feel that they are still capable and not just defined by their illness. We're mitigating that psychological impact of just being a passive recipient of care.
Okay, and let's quickly review the 3 stages of separation anxiety, because these can pop up in any kid who's away from their primary caregiver for a long time.
These stages are so critical to recognize. Stage 1 is protest. Loud crying, screaming, demanding the parent return, clinging.
The obvious distress.
Very obvious. Stage 2 is despair. The child becomes withdrawn, sad, quiet, inactive. They might just look mournful. And they often start crying again when the parent returns, which shows the deep pain of that separation.
And the 3rd stage, denial, is the tricky one.
It's very tricky. Or detachment. The child appears happy, they're making friends with the staff, they're showing interest in things.
And that's the dangerous trap, right?
It is. It's so deceptive. The child might stop protesting when the parent leaves and not even cry when they come back. So the staff and parents think, oh, great, they've adjusted. But this behavior is a defense mechanism. The child has essentially detached emotionally to cope with the pain. The nurse has to recognize that detachment as a sign of stress, not compliance.
Okay, let's dive into the acute conditions. When a child's respiratory function starts to fail, that shift is rapid. So triage requires nurses to instantly recognize the difference between compensation and true failure.
Right, and we use a 3-level continuum to guide our immediate response.
So let's start with where the body is actively compensating. Mild respiratory distress. What's the classic presentation?
The initial signs are often subtle. They're driven by the body trying to increase oxygen delivery. So we see restlessness, and that's usually the earliest sign of hypoxia.
Restlessness.
Restlessness first. Then tachypnea, so increased respiratory rate, tachycardia, increased heart rate, and diaphoresis, or sweating. If you see a kid who's anxious and breathing fast, your internal alarm should be going off.
So restlessness should immediately make you check their O2 sat and their work of breathing.
Immediately. And if that compensation fails, we move into moderate distress or early decompensation. Now the signs are much more visible. The respiratory muscles are really struggling.
What does that look like?
You'll see definitive nasal flaring. You'll hear audible grunting on expiration.
Which is the body trying to create its own PEEP, right?
Exactly. It's trying to keep the alveoli open. And you'll see visible retractions.
Where should we be looking for those?
Generally, suprasternal retractions, so above the sternum, are often observed first. It's a clear sign of high accessory muscle use. The child will also be getting more anxious, maybe confused, from the worsening hypoxemia.
And what's the key NCLEX point about blood pressure here?
The key point is that hypertension is a late sign. You might see the blood pressure start to climb, which indicates severe physiological stress, but it is not a reliable early indicator. You can't wait for that.
So once those compensatory mechanisms are overwhelmed, we hit the real danger zone. Severe distress, or imminent arrest. What are the ominous signs that demand immediate critical action?
The heart rate is the most critical marker here. The child develops profound dyspnea, very labored breathing. You'll see significant changes in their mental status, stupor, or even coma, and most dangerously, bradycardia.
So they go from tachycardia to bradycardia.
Right. Tachycardia is compensation, bradycardia is failure. A child in severe respiratory distress whose heart rate starts to drop is heading directly toward cardiopulmonary arrest. That is a moment to call for help and prepare for intubation.
And let's repeat the single most critical triage rule for children when it comes to color. Where is cyanosis on this continuum?
Cyanosis is a late sign, so late you cannot wait for the child to turn blue. Hemoglobin has to be significantly desaturated before you'll notice it clinically, especially in kids with darker skin. You have to rely on those earlier signs, restlessness, tachycardia, and crucially, that shift to bradycardia. Never, ever wait for cyanosis.
Okay, let's talk croup syndromes. They're all defined by that characteristic cough, but differentiating the common viral LTB from the bacterial acutus, acute epiglottitis is, well, it's one of the highest yield safety topics on the exam.
It really is. Failure to differentiate can lead to death. It's that serious.
So let's start with LTB, laryngotracheobronchitis. This is the vast majority of croup cases, and it's usually managed pretty conservatively.
Right. LTB is an inflammatory condition with swelling and narrowing in the subglottic area, so below the vocal cords. The cause is overwhelmingly viral RSV, parainfluenza, influenza A and B.
And it has a classic gradual onset.
Very gradual. Often starts with a low-grade fever, some URI symptoms. The hallmark signs are that harsh, barking, seal-like cough, and inspiratory stridor. And kids often seem significantly worse at night.
So how do we manage this common viral infection? What's the plan?
Management is all about reducing that edema and maintaining the airway. We use high humidity with cool mist, which is really effective, it's non-invasive, and it's much safer than steam.
And for more moderate to severe cases?
For those, we give nebulized treatments. Racemic epinephrine is a potent alpha agonist. It causes rapid vasoconstriction, which shrinks the mucosal edema in that subglottic area. We also give corticosteroids like dexamethasone to reduce the overall inflammation.
And what's the crucial nursing role here?
Keep the child calm. Parental presence is a powerful non-pharmacological treatment. When you reduce their anxiety, you decrease their oxygen demand and their respiratory effort.
Okay, now let's contrast that with the nightmare scenario, acute epiglottitis, a true medical emergency.
It is. This is a severe, rapidly progressive bacterial infection. It's most commonly caused by Haemophilus influenza type B, or high B, which is exactly why the high B vaccine has been so effective in preventing it.
And here the swelling is in a different place.
Completely different. Epiglottitis causes severe swelling of the supraglottic area, so above the vocal cords, including the epiglottis itself. And because that inflammation is supraglottic, it can just slam the airway shut completely and rapidly.
So what is that classic, life-threatening presentation we have to memorize?
The onset is abrupt, often within hours. The child presents with what we call the 4Ds. They're usually in the tripod position, sitting upright, leaning forward, chin out, just trying to maximize their airway opening.
Okay, tripod position. What else?
They have a sudden, intense sore throat, which leads to drooling because swallowing is impossible or just too painful. They have a muffled or whispering voice, often called the hot potato voice or dysphonia, and they will be highly febrile, tachycardic, and extremely restless from the hypoxia.
This is the moment where nursing intervention can either save the child or fatally compromise them. What is the cardinal rule?
Do not attempt to visualize the throat. Do not use a tongue glade. Do not give oral fluids. Do not even try to get a throat culture.
Anything that makes them gag.
Anything.
Right.
Manipulation, agitation, provoking the gag reflex. It can trigger a laryngeal spasm, leading to instantaneous complete airway obstruction.
So if you suspect epiglottitis, what's the sequence?
You maintain their position of comfort, you get help immediately, and you secure the airway in a controlled environment, like the operating room. The priorities are strictly maintaining a patent airway without causing any agitation.
So the sequence is?
The sequence is, do not agitate, position for comfort. Immediate oxygen, usually blow-by to avoid agitation. Then prepare for emergency airway management. After that, IV fluids and antibiotics. Diagnosis is usually confirmed in the OR after the airway is totally secure.
Okay, let's shift gears to sudden infant death syndrome, or SIDS. It's still a significant cause of infant mortality, usually between 2 and 4 months of age. For NCLEX, this is all about parent education and postmortem nursing care.
Exactly. And the core of the prevention strategy is the Back to Sleep campaign. You always place infants on their back for every sleep. And we have to detail all the other environmental factors that increase the risk.
So what are those specific risk factors and the counseling points that come from them?
The big risk factors are prone or side sleeping, soft sleep surfaces, loose bedding, and hyperthermia or overheating. So the counseling has to focus on creating a safe sleep environment.
A firm mattress, nothing else in the crib.
Exactly. A firm mattress, no loose blankets, no pillows, no bumpers, no toys. And we also strongly discourage co-sleeping, so the infant sleeping in the same bed as the parent.
I remember the source material mentioned that using a pacifier is actually a protective factor.
It is. The mechanism isn't fully understood, but statistically it is protective against SIDS. And we also have to counsel parents that both maternal smoking during pregnancy and any secondhand smoke exposure significantly increase the risk.
So let's talk about the nursing care after a side-eyes event. It's such an emotionally charged situation. How do we support that grieving family?
The care is based on compassion and addressing the family's intense feelings of guilt and loss. The nurse should absolutely facilitate the grieving process by allowing the parents and even older siblings to hold, touch, and rock the infant.
They need that chance to say goodbye.
They need that time. We provide a compassionate space and time.
And why is the autopsy necessary in these cases? It seems like it would be so hard for the parents.
It is, but SIDS is a diagnosis of exclusion. We need the autopsy to rule out any underlying medical conditions, like a cardiac anomaly or even abuse that might have caused the death. We have to reassure the parents that this is a necessary step to confirm the cause and provide closure, and it also provides essential data for future SIDS research.
Okay, let's move into our chronic condition masterclass, starting with asthma. It's the most common chronic childhood illness, also known as reactive airway disease.
Right. We define it as chronic airway inflammation combined with an exaggerated bronchoconstriction in response to various stimuli.
So what's the primary mechanism here that really defines asthma?
The core pathology is really two interconnected issues. First, you have an inflammatory response with eosinophils and mast cells that results in mucosal edema, increased mucus production, and sloughing of epithelial cells.
So the airway gets swollen and filled with junk.
Basically. And second, that same inflammation causes the smooth muscle around the bronchioles to become hyperresponsive, leading to bronchospasm. So this dual action, the swelling and the squeezing, results in significant airflow resistance and air trapping.
And the chronic danger here isn't just the acute attack, it's the long-term changes to the airway. Let's expand on this idea of airway remodeling.
Airway remodeling is the irreversible, progressive change that happens because of chronic, poorly controlled inflammation. It involves three major structural changes. Smooth muscle hypertrophy, so the muscles thicken and get larger, making them more powerful when they constrict.
Okay.
Then you have basement membrane thickening and the development of subepithelial fibrosis, which is basically scar tissue.
So the airway itself is physically changing for the worse.
It's permanently narrowing and becoming more hyperresponsive, which makes future exacerbations more frequent and more severe. And that's why preventative daily medication is so critical. We're trying to stop the remodeling.
We're treating the acute symptoms, but we're medicating primarily to prevent that permanent structural damage. What are the key triggers, especially when we contrast infants versus older children?
In infants and young children, the sources really emphasize that viral infections are the most common triggers for exacerbations. They cause inflammation that directly increases airway reactivity.
And as they get older?
As they get older, external factors become more dominant. Allergens like pollen, dander, dust mites, and irritants like tobacco smoke, strong odors, and exercise.
Okay, so how do we differentiate the signs of asthma from other respiratory problems like LTB or pneumonia?
The classic presentation of asthma is a non-productive cough, dry and hacking paired with audible wheezing, particularly on expiration.
And wheezing is the sound of air being forced through constricted airways.
Exactly. It's very different from the stridor of LTB, which is an upper airway obstruction, or the rales and productive cough of pneumonia, which is a lower airway infection with fluid.
During an acute attack, or status asthmaticus, what's the priority assessment?
The priority is continuous pulse oximetry to track their oxygenation. But we also have to recognize that severe, life-threatening asthma can present with diminished or even absent wheezing.
The silent chest.
The silent chest. And that's a terrible sign. It means airflow is so severely limited that there's not even enough air moving to create a wheeze.
For long-term management, the peak flow meter is essential. Can you walk us through the precise NCLEX teaching points for using this device?
The use has to be standardized to be accurate. The teaching involves three crucial steps. First, the child must stand up straight and blow out as hard and as fast as possible. One single blow.
Okay, stand up, blow hard.
Second, they do this routine 3 times, waiting about 30 seconds between each attempt. And third, and this is key, they record the highest of the 3 readings, not the average.
The highest reading. And why is establishing their personal best so important?
Because their entire action plan is based on zones relative to that personal best. The green zone, 80 to 100% of personal best, means they're stable. Yellow zone, 50 to 79%, means caution. They need to use their quick relief inhaler and probably call their provider.
And the red zone?
The red zone, below 50%, is a medical alert. Immediate use of a rescue inhaler and urgent medical attention. It signals impending severe respiratory failure.
All right, let's get into the pharmacology. The treatment of asthma requires a really clear distinction between the two goals: acute rescue versus chronic prevention.
For quick relief or rescue, we are focused entirely on opening the bronchioles and opening them fast. The key agents are the short-acting beta-2 agonists, or SABAs,
Albuterol.
albuterol, metoprolol, terbutaline. These are bronchodilators. They stimulate beta-2 receptors in the lungs, causing smooth muscle relaxation. NCLEX emphasizes that SABAs are the first-line treatment for any acute severe episode. They work fast, but they have no anti-inflammatory benefit.
Okay, so now let's move to the foundation of long-term control, the preventative drugs that actually fight the inflammation and the remodeling.
The cornerstone of chronic management is inhaled corticosteroids. These are the most effective anti-inflammatory agents we have. They reduce mucus production, decrease edema, and lower that airway hyperresponsiveness.
And what's the NCLEX watch point for kids on long-term inhaled steroids?
It's monitoring for potential systemic effects, specifically slowed growth. While they cause way fewer systemic side effects than oral steroids, the nurse has to monitor height and weight frequently. It's often minor and they catch up later, but monitoring is non-negotiable.
Okay, we also have preventative drugs that aren't steroids. Let's talk about mast cell stabilizers and leukotriene modifiers.
Sure, cromolyn sodium is a mast cell stabilizer. It works by stabilizing the cell membranes of mast cells and inhibiting the release of inflammatory mediators like histamine. But crucially, cromolyn is purely preventative. It has to be taken daily, and it has no effect during an acute attack.
And leukotriene modifiers.
Like montelukast. They work by blocking the action of leukotrienes, which are powerful inflammatory chemicals.
And finally, that older class of bronchodilator that comes with high monitoring requirements, theophylline.
Right. Theophylline is often used for severe nocturnal asthma. But because it has such a narrow therapeutic range, nurses have to diligently monitor serum levels to prevent toxicity.
And toxicity looks like what?
It can manifest as tachycardia, nausea, vomiting, or in severe cases, seizures and cardiac arrhythmias. Because of those risks, it's generally considered a third-line agent now.
Okay, so medications alone aren't enough. Nursing interventions and environmental controls play a massive role here.
A huge role.
What's the most immediate non-pharmacological intervention during an acute attack?
Managing anxiety. A calm, reassuring nursing presence, allowing the child to sit upright in their position of comfort, and making sure the parents can stay present. It's all critical. The act of struggling to breathe is terrifying. Reducing that emotional effort directly translates into reduced respiratory demand.
And for long-term control at home, we need to focus on allergen avoidance.
Absolutely. Environmental controls are paramount. Specific high-yield recommendations include replacing bedroom carpets with hard floors like tile because carpets trap allergens and dust mites. Eliminating smoke from all sources, including fireplaces and tobacco, is non-negotiable. Using air conditioning instead of open windows to reduce pollen exposure. And using allergen-proof mattress and pillow covers is a key way to reduce dust mite exposure.
Okay, if an NCLEX question presents 4 sports and asks which is most suitable for a child with asthma, what's the answer and why?
The answer is almost always swimming. The rationale is twofold. The horizontal position promotes optimal lung expansion, and the breathing control it requires is beneficial. But crucially, the air around the pool is humidified, which reduces the trigger effect of cold, dry air that's often associated with exercise-induced bronchospasm.
Okay, let's move on to our second chronic condition masterclass, cystic fibrosis or CF.
Right, CF is the most common lethal genetic illness among Caucasian children. It's an autosomal recessive trait, which means both parents have to carry a defective gene for the child to get the condition, and it's a multi-system exocrine gland dysfunction.
The root cause is a single protein defect. Let's break down how the CFTR protein defect creates such widespread havoc across the respiratory, GI, and sweat gland systems.
Okay, so the CFTR protein is a channel. Its job is to transport chloride ions across cell membranes. In CF, this protein is defective or it's just absent. So when chloride can't exit the cell, water doesn't follow it out, and that leads to impaired water secretion.
And the result is?
The defining result across all exocrine systems is the production of thick, sticky, dehydrated mucus. And this mucus then causes obstruction everywhere.
Let's track that path of destruction, starting with the respiratory system, which is usually the cause of mortality.
The thick mucus plugs the small airways and bronchioles. And this stagnation is a perfect breeding ground for bacteria, often Pseudomonas aeruginosa. So the cycle is mucus block, which leads to chronic infection, which leads to inflammation, which leads to irreversible tissue damage.
And that damage has a specific name, right?
It's called bronchiectasis. It permanently widens and scars the airways. And this whole process leads to decreased O2-CO2 exchange, causing chronic hypoxia, hypercapnia, and respiratory acidosis.
And what's the final stage of that respiratory destruction, the link to heart failure?
Due to the chronic hypoxia, the pulmonary blood vessels constrict. This increases resistance in the lungs, leading to pulmonary hypertension. The right side of the heart, which pumps blood into the lungs, has to struggle against this resistance, and eventually it fails. That's right-sided heart failure, or cor pulmonale,
A major sign of end-stage CF.
a very major sign.
Okay, let's move to the GI system and the profound malabsorption issues.
It's the same mechanism. The same thick secretions block the pancreatic ducts. This prevents digestive enzymes, lipase, amylase, protease, from reaching the duodenum. So without those enzymes, food just can't be broken down or absorbed.
And that leads to the classic GI symptoms.
It leads to impaired fat digestion, resulting in steatorrhea, those bulky, frothy, extremely foul-smelling stools, and impaired protein digestion, causing azoturia. This cycle leads to severe nutritional deficits and failure to thrive, even though these kids often eat huge amounts of food.
And finally, the unique electrolyte impact, the salty sweat.
Exactly. In the sweat glands, the defective CFTR protein prevents the reabsorption of salt back into the body. So the sweat glands excrete abnormally high levels of sodium and chloride.
Which is why parents report that their kids taste salty.
That's the classic sign they notice. And clinically, this makes the child susceptible to dehydration, heat exhaustion, and electrolyte imbalances like hyponatremia, especially in hot weather.
Okay, so what is the absolute earliest postnatal manifestation of CF? The thing that should immediately flag the condition in a newborn?
The earliest sign, in about 10% of cases, is meconium ileus. This is an intestinal obstruction caused by extremely thick meconium that the newborn can't pass in the first 24 to 48 hours of life. If you have a neonate with delayed or absent meconium, CF has to be on your radar.
And beyond the newborn period, what are the key signs?
Progressive COPD, frequent respiratory infections, a persistent dry hacking cough, and later you'll see advanced signs like clubbing of the fingers and toes from the chronic hypoxia and nasal polyps.
And what does the nutritional picture look like?
The classic picture is failure to thrive and tissue wasting, despite an often increased or even voracious appetite. You also see delayed puberty in girls and often sterility in boys because the vas deferens are blocked.
So how is CF definitively diagnosed?
The gold standard for diagnosis is the quantitative sweat chloride test. It measures the chloride concentration in the sweat. An elevation of sodium and chloride 2 to 5 times the normal amount, specifically a chloride level greater than 60 MEQL, is diagnostic of CF.
So management is complex. It's daily aggressive intervention, targeting both mucus clearance and enzyme replacement. Let's tackle the respiratory side first.
Priority 1 is airway clearance. And we have to remember the crucial sequencing. Aerosol bronchodilator medication must be administered before chest physiotherapy, or CPT.
That's a classic NCLEX question.
A very common one. The bronchodilator opens up the constricted bronchioles, which allows the CPT techniques to be far more effective in mobilizing those thick secretions.
And what are the specifics of the CPT technique itself?
CPT involves rhythmic percussion and vibration, along with postural drainage. It has to be performed using cupped hands. Percussion with flat hands is painful, and it's ineffective. And it needs to be done regularly, often twice a day, with the patient changing positions to drain different lung segments.
What medication is specifically designed to thin that thick, sticky mucus?
That would be the mucolytics, specifically DNase, also known as Dornase alpha. The mechanism here is brilliant. The thick CF mucus is rich in extracellular DNA released by inflammatory cells. DNase breaks down these DNA strands, dramatically decreasing the viscosity of the mucus.
And what's the high-yield adverse effect associated with DNase?
The most common one is voice alterations or laryngitis. Nurses have to counsel patients and families that this is a common, manageable side effect and not a sign that they're getting worse.
Turning to the GI system, how do we treat the pancreatic enzyme deficiency?
With enzyme replacement therapy, like Zenpap or Creon, the high-yield teaching points are all about timing and effectiveness. The enzymes have to be administered with every single meal and every single snack.
And how do you know if the dose is right?
You titrate it based on stool consistency. If the child is having frequent, bulky, foul-smelling stools, that means the dose is too low and it needs to be increased.
And how do they take them?
They should be swallowed whole. Or, if the child can't swallow capsules, they can be sprinkled on a small amount of acidic food, like applesauce, and taken at the very beginning of the meal or snack.
So the enzymes are there right when the food arrives.
Exactly. And given the severe malabsorption, the diet has to be very specific.
What does that look like?
It's a huge challenge. The patient needs a high-protein, high-calorie diet, often 150% of the normal recommended daily value, to compensate for the malabsorption and the high caloric expenditure from chronic infection.
And supplements.
Aggressive supplementation of the fat-soluble vitamins A, D, E, and K. And they often need salt supplementation as well, especially during periods of high sweat loss.
The management is so intense, but the prognosis has improved dramatically. What's the current outlook?
The predicted life expectancy is now in the late 40s, around 46 to 48 years. Lung transplants can offer significant benefit, but it's not a cure. The median survival post-transplant is only about 5 years.
Okay, let's move into a consolidated, rapid-fire review of high-stakes safety scenarios. These are the triage questions that test your ability to connect pathog to immediate action.
Let's do it.
Let's start with a common procedure. Tonsillectomy post-op care. What is the #1 primary indicator of a post-op hemorrhage, even if the child is asleep?
Frequent or continuous swallowing. It's a critical sign. It means blood is pooling in the pharynx and the child is reflexively swallowing it. You have to report that to the surgeon immediately.
And what's the priority positioning for a child immediately after a tonsillectomy?
They should be positioned on their abdomen, so prone, or on their side until they are fully awake. This position allows for drainage of any secretions or blood, preventing aspiration. And you also tell them no straws, no frequent coughing.
Okay, next scenario. A trauma. A child presents with a sucking chest wound. What is the immediate priority intervention?
Air is getting into the pleural space, creating a pneumothorax. The priority is to cover the wound immediately with an air-occlusive dressing taped on 3 sides.
Creating a one-way valve.
Exactly. It seals the hole to prevent more air from getting in, but it still allows trapped air to escape during expiration.
Let's review CPR in children. For a lone rescuer, what is the compression-to-breath ratio for all pediatric ages?
For a lone rescuer, it is 30 compressions to 2 breaths. That 30-to-2 ratio applies universally. If a second rescuer shows up, the ratio for infants and children shifts to 15 compressions to 2 breaths.
Finally, carbon monoxide poisoning. This is dangerous because a standard pulse oximeter can be misleading. Why is that?
Carbon monoxide binds to hemoglobin with an affinity 200 times greater than oxygen, forming carboxyhemoglobin. A standard pulse ox can't tell the difference between carboxyhemoglobin and oxyhemoglobin, so the SO2 reading might look normal, giving you a false sense of security.
So what do you need to monitor?
You have to monitor arterial blood gases, ABGs, specifically looking for elevated carboxyhemoglobin levels. And the priority nursing action is immediate administration of 100% high-flow oxygen to try and displace that CO.
Okay, let's nail down some specific testable drug facts. A child is being treated for tuberculosis with rifampin. What's the non-alarming expected side effect we have to educate the family about?
Rifampin causes an expected but harmless side effect of orange or reddish-orange discoloration of urine, sweat, and tears. It's crucial to counsel on that so they don't panic and stop the medication.
How should parents be taught to use over-the-counter nasal decongestants for infants with congestion?
First, they should avoid using vasoconstrictive nose drops for more than 3 days. Prolonged use causes severe rebound congestion. And second, the drop should be administered before feedings to clear the nasal passages, which helps with that obligatory nose breathing.
Last one. A child with strep throat starts antibiotics. When can they safely go back to school?
They can go back after taking antibiotics for a full 24 hours. By that time, they are no longer contagious, even if they still have a sore throat. You have to stress that they must finish the full course of antibiotics.
That was an intensive, high-yield deep dive. We covered the vulnerability of the child's airway, the crucial difference between LTB and epiglottitis, and the chronic management frameworks for asthma and CF.
Remember, NCLEX is testing your clinical reasoning, not just recall. So when you see an intervention, like giving racemic epinephrine for croup or pancreatic enzymes for CF, force yourself to visualize the underlying pathology.
Connect the why to the what.
Exactly. Why do bronchodilators come before CPT? Because you need to open the door before you start trying to sweep out the mucus. That connection makes it stick.
That's excellent advice. And as a final provocative thought to integrate into your studies, we spent time discussing the stress of hospitalization at different developmental stages, the toddler seeing illness as punishment, the school-age child craving a sense of industry. Consider how those deep-seated fears and needs profoundly impact a family's ability to maintain the high-demand, daily compliance needed for chronic illnesses like CF. The nursing process has to merge the biology with the psychology, always.
Recognizing that link is what separates a knowledgeable student from a truly expert nurse.
That's all the time we have for this deep dive. Keep that clinical reasoning sharp and keep diving deep into your studies. You've earned this knowledge.